The question is an interesting one and talks about whether we should give statins to all adults. And the guidelines didn't go that far. It's certainly a reasonable thing to consider, but in this day and age, many patients are reluctant to go on prescription medicine for the next few decades. So they're more apt to do that if indeed they think it's going to improve their long-term health. So better assessments of one's family history and determining what their lifestyle habits are, I think, can help us determine who we might push more to considering statin medicine. We all want to try to optimize better dietary and exercise habits in all our patients. But I think it's important to realize that we're not probably at the stage yet where we're going to convince 95% of the American population to start taking a prescription medicine at age 40. It's going to be trying to identify the people who are at higher risk. And selective use of the coronary artery calcium scan can be helpful, as well as a good medical history and assessment of other risk factors. So the question dealing with polypill is a little more complicated than it was a few years ago. Most polypills contained a low dose of aspirin in the past, and now we have 3 very large trials in primary prevention that showed modest decreases in cardiac events that were nearly counterbalanced by an increase in GI bleeding. So a polypill that contains aspirin probably is not needed. What we have much better data on now is long-term management of blood pressure and long-term management of cholesterol. So there may come a point in time when in individuals who, systolic blood pressures are consistently above 140 or diastolics consistently above 90, or LDLs consistently above 100, that a polypill might be considered, a combination of a statin and maybe a calcium channel blocker. So there's some blood pressure medications that you need to check kidney function on. So a polypill that contains an ACE inhibitor, an angiotensin receptor blocker, or a diuretic probably is not feasible, because there's always a chance that those classes of medicines might interfere with kidney function, potassium, etc. But a calcium channel blocker such as amlodipine might be a safe thing in conjunction with a statin. So the polypills of the future will probably deal with cholesterol and blood pressure, but not with aspirin. The answer is no. I think I wouldn't recommend blanket use of any therapy to very low-risk individuals. There's always a very small incidence of hypersensitivity reactions, side effects, and the challenge that we have now is trying to do a better job of identifying the people who are likely at higher than desired risk of having a heart attack or stroke. So I think the guidelines are very helpful with these risk-enhancing features and lowering the bar of the intermediate risk group to selectively consider additional testing, such as a coronary artery calcium scan. But we're not there yet for widespread use of PCSK9 inhibitors. The data that we have is in very high-risk people that predominantly had a heart attack or peripheral arterial disease, or people who had a recent acute coronary syndrome. And even there, it's been difficult to show a clear decrease in total mortality. We do see a nice decrease in morbidity, meaning decreases in subsequent heart attacks and revascularizations. But as time goes on and with longer follow-up, there may be more compelling data that PCSK9 inhibitors do have a bigger impact not only on morbidity but also on mortality. So another good question. I think most of us prefer the concept of the vulnerable patient. So far we've had very little success in easy identification of the vulnerable plaque, but people who have atherosclerosis are more vulnerable to future cardiovascular events. So I think the field is move to trying to identify those people with risk-enhancing factors or those people who have atherosclerosis on some sort of imaging study. The best data we have is with coronary artery calcium scans from longitudinal studies such as MESA and ERIC. But the idea that we'll do a coronary angiogram and try to determine with a specialized invasive technique who has vulnerable plaques or not, I don't think is really viable. So it's more an emphasis on the vulnerable patient.